We'll start right now by welcoming Mr. BJ Realubit to the floor. Mr. BJ Realubit is a registered nurse, a clinical coordinator for the Kidney Transplant Assessment Program at the Ajmera Transplant Center University Health Network. He holds a Bachelor of Nursing Science from Queen's University, 2003, and a Master of Nursing, Nursing Administration, 2007. With over 18 years of nursing experience, his main clinical focus involves solid organ transplantation and working with recipients and transplant candidates throughout the continuum of care. He has held various clinical and leadership roles as a staff nurse, nurse educator, patient care coordinator, and nurse manager in Toronto and in Vancouver, BC. He is an active participant in the High School Outreach Initiative, promoting organ and tissue donor awareness to students in the Greater Toronto Area during their academic school year. So without further ado, BJ, welcome, and we'll start your presentation.
Good morning. My name is BJ Realubit, a clinical coordinator here at the Ajmera Transplant Center in Toronto, Canada. Thank you for the opportunity to be with you here today. My clinical experience revolves mainly around transplant patients for the last 18 years as a registered nurse. I'll be talking to you today about kidney transplant and a patient's journey. We'll be focusing on the surgery, briefly giving you a high-level overview of what that will look like. We'll talk about the Trillium Gift of Life Network and why that organization is so important for us here when it comes to the transplant world. We'll focus on the transplant assessment process. Really, what are all those checks and balances that are required for us to deem you safe to proceed with a transplant? We'll talk about a referral process, the evaluation, what it means to be on the wait list, and also in terms of life after transplant, what our kidney transplant recipients can expect to experience post-transplant in terms of the blood work, the follow-up, and the medication. So the transplant program here at the University Health Network has a long history. We've been around since 1965. We currently perform approximately about 600 transplants every year. This includes not only kidney transplants, but also pancreas, lung, liver, heart, eye, and intestine transplants. Regarding the kidney transplant world, we perform about 160 to 180 transplants every year. And we currently follow over 5,000 patients in our post-transplant clinic. So we're a very busy program. In terms of the kidney transplant surgery, it generally takes about 3 to 4 hours to conduct. The kidneys you were born with through native kidneys typically stay with you unless they've caused a lot of issues with previous chronic infections, for example, or they're too big where we can't actually put a third kidney into your abdomen, for example. In terms of the transplanted kidney, you receive the kidney, a piece of the donor artery and vein, and the donor ureter. So all of these connections and tissues and vessels will be attached to your anatomy, as you can see in the diagram here. Generally, for a polycystic kidney patients, we will assess at the time of our transplant surgery surgeon assessment whether or not a native nephrectomy is required. And generally, our preference is either to take a kidney out if we need to, either before or after the transplant. We generally don't like to perform the surgery at the time of transplant due to the fact it can prolong the surgery and a patient's time under anesthesia. And also in the event that there was a complication or a concern, we really do not want to jeopardize the transplanted kidney in any way. And so this conversation will be had by your respective physicians to assess your types of symptoms, your pain, your discomfort, and really the necessity to be able to make this decision with our surgical teams here. In terms of transplants, generally there's two main pathways, either living donation or deceased donation. In terms of living donation, this is typically from a donor who's 18 years of age or older. They're typically healthy and willing to freely donate. They can be a relative, a friend, a coworker, or potentially a complete stranger. The majority of living donor transplants we actually do within our program are patients who do not have a genetic relationship with each other. So it really is important when you're looking at the options for living donation to look beyond your family, look beyond your dinner table and your household for potential options. Generally, with a living donor transplant, the wait times for these types of transplants are usually lower, and oftentimes they can provide ideal and better outcomes than deceased donation. So we typically quote on average a living donor transplant can provide a recipient about 18 to 20 years of reasonable graft function on average. Again, some less than that, some more. And when you compare that from deceased donation, which accounts for about 2/3 of our activity, this is an organ from obviously somebody who's passed away. Typically, it's anonymous, so you won't know who the donor is. And essentially, patients wait on the deceased donor list until a suitable match is found. And so, again, this can be many, many years after the evaluation has taken place. Again, depending on your time on dialysis and your blood type, as well as your antibody level, which we'll talk about later. And generally, from a deceased donation transplant, recipients can typically expect anywhere from about 12 to 15 years on average of reasonable graft function. The length of how long a kidney transplant will last is a very complicated question, but it basically boils down to a patient's health, a recipient's health at the time of transplant, the health of that donor kidney at the time of transplant, and also how the recipient continues to manage and maintain and optimize their health moving forward post-transplant. We pause here to talk about the kidney paired donation program. So this is in the event you do have a living donor, but they're not able to give to you directly because of a blood type mismatch, or because there are the presence of what we call donor-specific antibodies. And essentially, this program has been established since 2009. It involves all of our partnering kidney transplant centers across the country. It basically enrolls all of these patients within this national database of all these incompatible pairs. And every month or every couple of months, the system tries to generate as many compatible transplants as possible with all of those patients who are currently in the system. Both the recipient and the donor would need to consent to be enrolled in this system. And for any pairs to move forward, both the donor and the recipient would need to match at the same time. And so matching timelines can vary. It can be 2 to 3 months before pairs are matched, sometimes 2 to 3 years. Sometimes pairs are unfortunately unable to match within the system. Once a match does happen, it's important to note that there's a lot of planning that is required, and sometimes it can take a couple of months before a surgery is planned. Generally, with the kidney pair donation program, we would like all of the pairs within a given chain to go with surgery within a reasonable time of each other. So typically within a month of each other's surgeries to really avoid the chances of potentially, a change in the recipient status or a donor deciding not to proceed with the program. And it's important to note that the program does have contingencies in place in the event that there is sort of unexpected changes either in a recipient or donor status with our matched pairs. So again, we'll have a conversation about the kidney pair donation in the event that direct donation is not possible for you and your donor. So as you know, your kidneys provide a number of functions that really allow you to survive from a day-to-day perspective. So that includes filtering waste products from your blood, filtering water from your blood, regulating things like your sodium, potassium, and calcium levels. They're really important in terms of your blood pressure control, your hemoglobin level, and also making sure your bones are healthy and strong. And so with a transplant, you're able to restore some of these hormonal and regulatory roles that cannot be substituted by dialysis. Many of you on the webinar today might be experiencing potassium restrictions, phosphate restrictions, even fluid restrictions. Typically post-transplant, the patient is without these restrictions, and essentially we ask that patients continue with a balanced and healthy diet, really to minimize sort of future risk around high blood pressure or high cholesterol, and making sure they continue to really have a good diet moving forward. With a transplant, we're hoping to provide really a quality of life benefit for many of our patients. So not having to go to dialysis 3 or 4 times a week, or go to be at home and perform peritoneal dialysis 6 or 7 days a week. As you know, there are some patients who may be on the call today who might be in their 70s or 80 years of age. And essentially, as a patient gets older, the life expectancy or survival benefit is really not as obvious. And so it's important as a patient considering transplant, really what you are trying to achieve for a transplant really needs to be a sort of a personal choice for you, because a transplant will not necessarily fix everything that's currently ailing you. And as we'll talk about in the next slide, there are potentially a number of risks that you can be predisposed to after you have the transplant. And so in terms of the medications that protect your kidney, the anti-rejection medications, these medications, although they protect your kidney and help it last as long as possible, these medications can also increase your risk for things like diabetes or cancer or infection. So it is something that our transplant teams are monitoring very closely, at the time of transplant and really for the rest of your life, really trying to reduce these risks and minimize both short-term and long-term impacts of these medications. And because of the fabulous medications that we do have in terms of the anti-rejection medications, we need to make sure that you take these medications as prescribed. Even missing a dose here or a dose there might mean that your kidney may only last, half as long as we would have hoped. And so it really is important, even though you're feeling well, you're feeling like a superhero, your creatinine's never been lower, you really need to take your medications as prescribed. So we'll pause here just to talk about the Trillium Gift of Life Network, TGLN. And really it's our government agency in the province of Ontario that really coordinates and develops policies around organ and tissue donation. And so part of it is really their responsibilities are developing these guidelines and listing criteria. They're really important in terms of policies, organ sharing policies between us and within the province, as well as 2 other provinces within Canada. And they also help us here in terms of analyzing our data as it relates to our transplant rates, donation rates, and really our survival rates. And so they're not involved in any specific clinical care. That's all up to the individual transplant centers here in Ontario. But again, they do provide consensus guidelines that all of the transplant centers do their best to abide by to make sure we all are practicing the standard of care and really following best practice. So as you can see here, we have the referral and listing criteria for the adult kidney transplant program. As you see, there are a number of different guidelines that TGLN provides for all different types of transplant populations. And so they will give us and have identified for our referring centers those absolute and relative contraindications for transplant. And they're all available on our public website at the giftoflife.on.ca website. So next, we'll talk about the transplant process. So here is really the overview from referral, evaluation, listing, the waiting period, and the transplant. And so we'll talk about all of these components as we move forward in the presentation. Generally, the first step is always the referral. And so this is a series of tests that we have outlined as part of our program. And each program within Canada may have slightly different variations of sort of the required referral package testing. And so it gives us a sense of your blood work, baseline health, baseline medical history, really to give our teams an understanding about how your current health may impact you as it relates to undergoing a transplant surgery and your recovery afterwards. Essentially, you're referred, most patients are referred by your transplant nephrologist, sometimes the family doctor, but generally it's your transplant nephrologist who will be responsible to manage anything that relates to your end-stage kidney disease. And essentially, the testing would be completed by your referring center. It usually takes anywhere from about 6 to 8 weeks potentially to complete. And the package would then be sent to our intake center here at the hospital. And so it can be sent by fax, by mail, or by email. And our team will review it and get back to you about what the next steps will be. In terms of the evaluation phase, it's important to know, just because a referral package is submitted, that you're not automatically put on a wait list. Again, there's a series of checks and balances that need to be had, a number of assessments and testing that is required before we can do that. And so again, we are checking for your suitability as a candidate. We're making sure that there's no surprises when it comes to the time of surgery. And ultimately, we're hoping that we will provide you the best chance of success at the time of transplant and moving forward. We'll do some compatibility testing, which we'll talk about later. Based on our assessment, our team may decide to do more testing. If there's a question or concern, either from the surgeon, anesthesiologist, or a transplant nephrologist, our team may refer you to other specialists or for repeat testing to make sure that there aren't any further issues that can be optimized or corrected before transplant. Ultimately, we want you to be at your best self, your healthiest self at the time of the surgery. So some of the tests that we do here is just a confirmation of your blood type. We do a human leukocyte antigen profile. So it's basically looking at your cells, understanding what your the protein markers on your cells look like, because that will be important for our future matching opportunities. We also look at your panel reactive antibody test. And so this test tells us how easy or how hard it is we think you're going to be able to match a donor from the general population. And so sometimes there are some patients based on previous transplants, previous pregnancies, previous blood transfusions, that because they've been exposed to sort of foreign tissue, their body may develop these antibodies that in the event that they get a transplant, they may have a higher tendency to start attacking that kidney as foreign and causing damage to the new transplanted kidney. And so your teams will talk to you further about this as you move on in your assessment. And one important thing we always check for is also the presence of infection. So we look at your previous infectious history, whether it's hepatitis or whether it's tuberculosis, and we want to make sure that that risk for disease flare-up or reactivation is as low as possible when it comes to being on these anti-rejection medications. So there's a series of blood work and a TB skin test that we typically do here at our center. We will also conduct, if there's a question or concern from your baseline testing, repeat x-rays or ultrasounds, just to look for any signs of fluid collection, for infection, potentially indications for lumps and bumps or cancer in your particular situation. And our teams will also assess the blood flow where we hope to connect the kidney to. So making sure those veins and arteries where we would hope to plug in a kidney will ensure that the new transplanted kidney gets the blood to survive and thrive post-transplant. So here at Toronto General, we essentially break down our evaluation into two steps. And the first step is really getting that initial blood work and that antibody testing, getting your HLA profile. You'll meet with a coordinator to really give you an overview of what similar topics we're talking about today, but they'll be able to give you a sense of what to expect over the next couple of weeks and months as it leads to your assessment. You'll also meet with a social worker just to talk about medication and drug coverage, things to start planning for accommodations or transportation in and around transplant. The first major assessment is with our transplant nephrologist. They'll review your file in terms of your individual risk and benefits as it relates to transplant. And again, they may order some additional testing or send you to a specialist if there's a question or concern. If you're okay from essentially a cardiac and lung perspective, we will move you on to the next phase of the assessment. It's again meeting one-on-one this time with a social worker to make sure that those plans are in place for things like medication coverage, your accommodations and transportation, how we develop those concrete plans, and do we have contingencies in place. We also look at things like your living will or your power of attorney. In the event that something unexpected at the time of transplant, do you and your family have a plan in place to be able to move forward and make decisions? We'll meet with the transplant surgeon to really look at, do we put a kidney on the right side or the left side? Is there space to put a kidney in? Do we have to take one out like we were talking about before? Or have you had major abdominal surgeries where there's a lot of scar tissue? And so there might be a challenge in terms of getting into your abdomen to perform a transplant. And lastly, you'll meet with the anesthesiologist. Essentially, they're going to be looking at your previous surgical history. Have you had any previous negative reactions or anaphylactic reactions to the anesthetics that they gave you? Do you have any issues with your airway in terms of your breathing, putting a breathing tube in? Is there going to be any problems there that we can plan and anticipate? And so until you complete the transplant nephrology assessment, the social worker assessment, anesthesia, and surgeon assessments, we can't make a decision about your safety to proceed. So it really takes all of these assessments to make that final decision. Once we're able to make that final decision and complete all those assessments, we take your file to our transplant committee. So it really is a program decision about whether or not you're safe to proceed. We make sure all of our questions and concerns are answered, make sure we have all of the appropriate documentation. Some of the decisions following this confirmation or listing committee is really that a patient's too early for transplant, a patient's too high risk, a patient suitable candidate for transplant with a living donor, or a patient is suitable and they can be waitlisted on the deceased donor list. So we'll talk about all of these potential outcomes in the next couple of slides. So some of our patients are defined as too early for transplant. Generally, our patients would need to have a GFR of 15 or less to be activated on the list. But it also depends, as you know, on a patient's symptoms in terms of, shortness of breath, restless leg, and pain issues as it relates to cramping and things like that. But again, we don't want to give you a transplant too soon. We essentially want to squeeze out all of the remaining kidney function before we give you a transplant, because there is a potential risk the longer you are on these immunosuppressant medications. And so again, we do hope to obviously provide patients who have not started dialysis a transplant before dialysis. Because again, there are associated risks of having a patient on dialysis. With these patients, obviously, early referral is key, and making sure that patients do have a living donor if they have a potential living donor in the event that they are pre-dialysis. In terms of a patient who is too high risk for a transplant, and so again, that might be because of cardiac disease or lung disease, or again, you might have extensive vascular disease where we can't connect the kidney to you because you're not going to get, that kidney is not going to get the adequate blood supply it needs. And so this happens about 2% of our total referral base, even less than that. So you're typically, going to be approved for transplant, but we just want to make sure that there's nothing there that we can't sort of optimize before the transplant. And in the event that you're deemed too high risk, we often offer those patients a second opinion at an alternate center, just to make sure that, again, we've done all we can for a patient. And if there's something else that can be done, it's always good to potentially get a second opinion. However, if the patient's deemed too high risk, those patients will remain on dialysis. And so our third outcome here is really being able to be suitable for transplant, but also have a potential living donor option. So as I said earlier, this really provides the best outcome as it relates to transplant. Obviously, the patient would need to have a healthy and compatible donor for us to proceed, either with direct donation or potentially the kidney pair donation program. As you probably heard in an earlier session around living donation, our donors typically do not experience no significant impact on their lifespan in the future. And there's very minimal risk in terms of, again, complications because of donation. And as we said, a living donor transplant does provide a patient the best outcome and really the shortest wait time. And there's a lot of planning and sort of pre-planning that we can do to be able to get this surgery underway. And the last outcome here is related to deceased donation transplant. So if we've exhausted all your living donors, or if you don't have any living donors, all of our patients will end up on the deceased donor transplant list. There really isn't anything you need to do differently as it relates to your assessment. Essentially, patients will wait on the wait list based on their blood type, their dialysis start date, and again, wait times can vary anywhere from 5 to 7 years potentially. And then organs are allocated through the provincial organ allocation system through the Trillium Gift of Life Network. So just talking about this list and what will impact your time to transplant, we'll cover that in a couple of slides. So in terms of wait time in Ontario, once patients are cleared for transplant and deemed suitable, typically, if you have a living donor who is cleared, it takes about 1 to 6 months on average to be able to book that surgery. For deceased donation, as I said, patients can be waiting upwards for 5 to 7 years from the start date of dialysis before they actually go to the OR. And so again, wait times will vary depending on your blood type, your antibody level, and your dialysis start time. Our goal here at our center is really to maximize a patient's donor opportunities, and especially as it relates to deceased donation. We essentially break up our donor pool into 3 main categories. The first category is the standard criteria donor. This is about 60% of our donors, and this typically involves donors who are 60 years of age or younger. Again, standard criteria donors typically waiting for a standard criteria donor usually involves the longest wait time. In terms of an expanded criteria donor, these are about 40% of the donors we see. These are older donors. So any donor who is 60 years of age or older is classified as an expanded criteria donor. A donor between the ages of 50 or 60 who may have passed away because of a stroke, had high blood pressure issues, or level of kidney disease at the time of their passing can also be classified as an expanded criteria donor. So these kidneys will be able to get a patient off dialysis, but because of the age of the kidneys or because of some of these health issues, they may not last the patient as long. So generally, we'd expect an expanded criteria donor to be more of benefit to a patient who is of older age. So if you're a recipient who's 55 years of age or older, or a patient who is difficult to match, we may talk to you about whether or not this expanded criteria donor pool would benefit you. And the last group of donors is what we call exceptional distribution donors. So these donors cover all age categories, but based on their medical history, they might have a higher risk of either passing on an infection or a cancer at the time of transplant. And so our teams will determine whether or not this donor pool would be a benefit to you. So again, if you're an older patient with a long wait time, or in the event that you are difficult to match, we may talk about the exceptional distribution donor pool for you. And so this is when we look at things like a patient who's had hepatitis B disease or hep C infection, and our teams will be able to talk to you about these donor options in the event we would think it would benefit you. So in terms of Ontario, essentially there's about currently, as of September 1st, about 1,000 patients waiting on our list for a deceased donor transplanted kidney. Essentially, every year, 500 patients get transplanted from this list, and another 500 gets added to the list. And so in terms of your wait time, we basically calculate and we'll measure how long you will wait from the time you started dialysis. So it doesn't matter which modality it was, so whether it's hemodialysis or peritoneal dialysis, we always go back to your original start date. It's impossible to know exactly how quickly you will get your transplant. So it depends on your blood type, it depends on your antibody level, your dialysis start date, as well as the rate of donation. And so, as you may know, here at Toronto General last year, during the first wave of the pandemic, we actually slowed our activity in terms of our kidney transplants. And so we were only transplanting patients who were medically urgent or patients who were highly sensitized. And so there may be weeks where we do a lot of transplants and get a lot of patients off the list. And there may be weeks and periods of time where we don't get as many donors that become available. And as we talked about, a patient's willingness to be open to as many donor pools as possible will hopefully increase their chance of finding a match sooner. So while you're waiting for a living or deceased donor transplant, it's important that you stay as healthy and active as possible. It's making sure that your vaccines are up to date, such as your flu shot, your hepatitis B, chickenpox, and now the COVID-19 vaccine. We want to make sure that you have received it. It really is important that you have a family doctor because it really will be your family doctor and your transplant team navigating most of your care post-transplant. And if you don't have a living donor and you're waiting for a deceased donor offer, it's always good to explore living donation at any time. And we also want to make sure we have your updated contact information. And this is primarily why. So getting the call for transplant, especially when it comes to deceased donation transplant, can happen 24 hours a day, 7 days a week. Unfortunately, we've had patients miss the opportunity for transplant because their cell phone was off, their battery was dead, their voicemail box was full, and we didn't have any alternate contact numbers available on file. Essentially, these patients will need to call back within an hour to be able to say they're on their way and they accept. Or if not, we go beyond the 60 minutes, essentially, we're going to go to the next person waiting on the list. All of these patients need to be willing and ready to come to the hospital as soon as possible to be able to start all the pre-op testing and getting everything arranged for you. In terms of your hospital stay, Essentially, patients can anticipate to stay for about 5 to 10 days. Again, depending on your course and how complicated it is, some patients may stay longer. However, we will do our best to discharge you home as quickly as possible. You'll learn about your medications and how to take them properly, what they're for, when you take them, how much to take, and any common side effects to look out for. We'll teach you about how to manage your incision, about the signs and symptoms of infection and rejection so that you're very familiar with those. Many of our patients will receive a Foley catheter, which is a tube in your bladder initially, just to make sure we're able to measure your urine output and making sure that your bladder doesn't get overly distended and start causing tension on all of these new connections. And that stays with you for a couple of days, but it will be removed by the time you go home. And in the event you have a PD catheter or hemodialysis line at the time of transplant, essentially we'll take that line out as quickly as possible once we are confident that the kidney is working. And so if you do have this line in situ, it is important that the line is still flushed, the dressing still changed, because we don't want you to have an infection because of a dirty dressing or a clot because of the fact the line wasn't flushed appropriately. And then your staples, all of our patients typically will have staples, and generally these will be removed about 10 to 14 days after the transplant. We pause here to talk about the transplant medications once again. So like I said, it's so important that you take these medications after your transplant as prescribed. They basically prevent your body from rejecting your new transplant. They must be taken every day at the right doses. And it's important that you don't run out. Some of these medications can cause weight gain, high blood pressure, high cholesterol. Some of them can cause mood changes. So anxiety or depression, commonly nausea, vomiting, and diarrhea. And some of these medications may also, like we talked about, increase your risk for infection. So there may be another handful of medications that you'll be discharged on, hopefully for only about 6 to 12 months post-transplant, in terms of antifungals, antivirals, other antimicrobial medications to reduce this risk. Your cancer risk is elevated. It's about 2 to 4 times higher than somebody who's not on anti-rejection medication. And so things like colon cancer screening, cervical screening, and mammograms are really important post-transplant. And also, making sure that you're not sun worshiping, because skin cancer is definitely a reality that many of our patients face post-transplant. And then there's still issues with osteoporosis. So most of our patients will go for a bone assessment or bone scan after transplant, just to make sure that we always will keep your bones healthy and strong, whether it's through medications or diet and exercise. But it really is important to make sure that we maintain the strength of your bones. So this will be something that's monitored post-transplant and lifelong. In terms of follow-up, coming to the post-transplant clinic is really important, definitely for the first 4 to 6 weeks. It's quite frequent and obviously quite tiring for many patients. But it's important to know that the reason we're doing this is to make sure we catch issues early on. And so you'll be coming to meet with the doctor and the nurse at least once a week and doing blood work at least twice a week. We want to make sure that in the event that we need to repeat blood work, we're able to do so really quickly. Or if you need to be admitted for high-dose anti-rejection medication, we're able to do that. Some patients may need to be sent for an urgent ultrasound of their kidney transplant and a potential renal biopsy. And so we do want to make sure that our patients are prepared to stay locally near our center for this period, especially if they live outside of Toronto, because the travel to and from can be very difficult in terms of early morning, and you're typically here half the day and then having to come back a couple days later. However, our hope is as you stabilize from a transplant and you're doing really, really well, we're only going to get you to do your blood work maybe every 3 to 4 months, and that you're only going to come to us once a year for your annual assessment. So essentially, the visits are quite intense initially, with the plan to back off and see you less and less frequently as you move away from your original surgical date and your kidney function stabilizes. So at each of your appointments, when you come to the transplant clinic, we really are going to be looking at your anti-rejection levels, making sure that they're not too high, not too low, just right, so that Goldilocks philosophy. We always want to make sure that you're getting the best protection from these medications, but also minimizing all of these long-term side effects, which I discussed. And we also want to make sure that there's no signs of infection. So if you have a new cough, new shortness of breath, difficulty breathing, or potentially pain or burning on urination, we want to make sure you don't have a bladder infection, because there are things like opportunistic infections that can happen because of your anti-rejection medication. We'll be looking for any signs of rejection. So watching your creatinine, your urine output, making sure that you're not swelling in your lower limbs, or your weight's not going up very quickly over a short amount of time, because oftentimes this can mean that you're holding on to fluid. And then lastly, we'll be looking at things like side effects from the medication and also your incision. And so there is a lifting restriction 3 months post-transplant, no more than 10 pounds, because of the major abdominal surgery you just had. The incision outside may look really nicely healed, but it's all those muscles and tissues underneath that are taking more time to heal. And so we would not want you to have to return to the OR because your wound has opened up or potentially got infected because of a weird movement or a quick bend or something like that. And so we will be here as part of your team lifelong. You will be assigned to a nurse, a transplant nurse, and a transplant doctor, really to help guide and support you for the months and years to come. And so you'll always be connected to us, essentially lifelong. And so that wraps up my talk for today. I really do appreciate the opportunity to be here today to spend with you to this national audience with the PKD Summit. And I really appreciate the time and hope that you gain some knowledge around the transplant journey here. So thank you very much, and stay safe, stay well, and take care.
Thank you, BJ, for a tremendous presentation. Lots of insightful information shared. We really appreciate that. Now we do have time, 15 minutes for Q&A. So I'll just run through those with you, BJ, and we'll see where we get. So one of the questions asked is there a donor network in the Atlantic provinces similar to the Trillium Gift of Life network?
So there definitely is. I guess in terms of organ body within the Atlantic provinces, I believe that also coordinates them. Obviously, I believe it. So yeah, so if you were to sort of Google that, you will be able to find that organization. I'm sorry that the name of the specific organization leaves me right now, but I do believe there is a specific organization out in the Atlantic provinces.
So I just looked it up, BJ. It's called the Multi-Organ Transplant Program of Atlantic Canada. So it's got a MOT back abbreviation, if that helps. That may make it more confusing for people. But definitely if you Google Atlantic Provinces Donor Network, it's the first to come up. We had a question I saw in the chat as well. What advice do you have, BJ, for people who are looking for strategies to advocate for their family and friends eligible for a kidney transplant during the pandemic? Opportunities to share your story are limited, and not everyone is comfortable sharing their story online. So kind of a twofold question. First, how to spread the knowledge of the need during a pandemic? And then specifically, if they're not comfortable with doing the online promotion.
No, for sure. It definitely is a hard and stressful conversation for our recipients. And so every time I say, go look for a living donor, I do not mean to sort of dismiss or minimize how difficult that is. Here at Toronto General, we do have the Center for Living Donation, where we're able to direct our possible donors and also our recipients to learn about the living donor process. So having that ask is very difficult, but ultimately, if you don't have that conversation, no one's going to be able to have that conversation for you. So we obviously encourage all of our recipients to learn about the process, learn as much information as you can about living donation and what the resources are. We stress in our initial education teachings here that we don't expect our recipients all of a sudden to be this expert in renal transplant as well as in living donation, but to know that there's resources out there where you can direct your family members and friends to is really important to do. And I would also add that sharing your story as best as you can, potentially with a very close friend or very close loved ones, and potentially getting them to share your story through networking and social groups and things like that might take the pressure obviously off of you as a recipient looking for a donor and any of the donors who may be approached. Because again, this conversation on that receiving end as well can be very difficult. But ultimately, there's a lot of people out there who might be willing to help if they only knew that you were potentially going through this. So again, those conversations are not easy. They're very stressful. They can be very awkward. But if you tap into some of the resources that may be available for donors, like our Center for Living Donation, it may give you different strategies to work on. And oftentimes we do get requests from potential donors or from recipients about how do they use social media. So that is a strategy. Obviously, some patients are more savvy than others, and that's okay. We obviously, as a center, do not take part actively in any of these media campaigns because obviously there's an organizational liability there. However, it is important that, again, you can sort of talk to people at your kidney care center who might have gone through the same sort of journey. Talk to your co-patients there potentially about what they might have done to be able to do that. And I know in Ontario we do have sort of transplant ambassadors as well as a resource to be able to sort of talk through some of these issues and sort of the practicalities of it. But again, having these conversations is ultimately up to the recipient. And again, we know it's difficult and it's definitely not easy.
I think mentioning TAP and the Transplant Ambassadors Program is huge. Speaking to someone who's been through the transplant, has come through the other side is invaluable. And I know that in this house alone, my wife recently donated 60% of her liver to her father. And, right before the transplant, she spoke with a mentor from UHN, and it was invaluable for her to, again, hear from someone. We've worked with your organization, the Center for Living Organ Donation, to develop Finding a Living Donor. So a video platform that has short vignettes that also teach people how to find a living donor. It does touch on the social aspect of it and the power of social media, but it does also engage in how to have those conversations with your close friends around the coffee table, at the church or the synagogue, or your place of worship. And we know that it's very hard. And one of the other questions that was asked touches to this. It was, how do you talk to someone who doesn't feel they're worthy of getting a transplant, or they don't want to be a burden to the healthcare system? And I think when you talk to someone who has been through the other side and you're learning about the quality of life and the fact that, their journey has inspired other people to register or to get involved in promotion is a big key component to that. There's a lot of people, we get it, and I don't know about you, BJ, but a lot of people that would rather wait for a deceased donor than a living donor, even though we know the results from a living donor are significantly better. But it's engaging them to have those conversations. So hopefully something that you've said today resonates with them. And they can reach out to our foundation as well. We're happy to help get the ball rolling and to point them in the right direction. We'll take it down a different direction. Can you speak about the policy changes internally regarding transplantation due to COVID? So changes in visitation perhaps, or other restrictions that may not occur during a transplant that is happening during a pandemic?
So yeah, that's a great question, and obviously we're still living through all of this in this fourth wave, and so our organization here has really done its best to limit obviously our visitor sort of allowances within the unit, just to make sure that again we're able to sort of control how many people are on the unit at one given time. Really trying to reduce the risk for both our recipients as well as our staff as well. But I know the organization has really moved to try to make this visitation policy as open as they can, but just knowing that, again, every patient or every visitor that enters our facility is a potential risk. And as we know that the community cases are starting to increase or have been increasing over the last couple of months, that we start to see an influx of those numbers in the cases within the hospital. And so part of that is the visitation piece. I also know during the pandemic, just getting sort of routine testing done was a big challenge. And as you know, all of our organizations across the country are dealing with a backlog of sort of routine testing and sort of assessment testing. And so we're continually trying to balance that. So certainly we're not out of the woods at this point in time. We promise, we do our best to say we will try to get you through the system as much as possible, but obviously our testing and assessments are contingent on all of the hospital resources available to us.
And that, of course, is ever changing. I imagine once you get comfortable with one set of rules, something shifts and you start from scratch with the policies. Well, thank you for the clarification. Is there a special diet to follow post-transplant?
Yeah, generally there isn't. Obviously, this is very individual to a particular patient. We essentially want patients to follow a very balanced and healthy diet. Again, the risk for hypertension, high blood pressure, high cholesterol are still a reality, not only because of your diet, because of also the medication you're taking. And so a lot of the problems sort of moving into sort of post-transplant life is around cardiovascular disease. And we want to do our best to try to minimize all of those as much as possible, so that again a patient is trying to sort of eat and drink as a balanced and healthy diet as much as they can. But again, it really is patient specific. There might be other health issues that you might be experiencing where you need to be a little bit more cognizant, but specifically for transplant, there isn't anything major that I can sort of recommend post-transplant.
So your traditional heart healthy diet for the most part that we all should be following.
Correct.
Understood. Okay. Can you talk about, there's a lot of misconceptions and misinformation about the age of transplantation and how that can be affected. Can you speak to the oldest patient perhaps that was transplanted at your institute?
So yeah, for sure. So we do not have a cutoff for our referral population. So that definitely is not true. I believe the oldest patient we transplanted here might be sort of mid 70s, 76, 77 at Toronto General. I believe across Canada, it could have been over 80, but again, we would have to sort of clarify that fact. But generally, you can have, an 80-year-old who's been running marathons for the last, 5 decades, or have a 30-year-old who has been smoking half their life. And right, so we definitely don't look at an age as sort of the limiting factor. Obviously, as you age, there may be sort of more additional perioperative risks, but that is certainly not a cutoff for transplant. And again, it really is a global look at your health and not specifically or solely on a age base.
Understood. Thank you. We'll expand on this question a bit, but specifically it's asking about one's sex life. They're asking how that will be affected post-transplant, but can we elaborate a bit and speak to the recovery period where obviously there are restrictions on the activities of what one can do and maybe when certain activities like driving can come back?
Yeah, no, for sure. So obviously, one's physical activities will vary post-transplant. Generally, in terms of lifting restrictions, again, it's that 10 pounds for the first 3 months, just because of that incisional piece. Obviously, the resumption of sexual activity is really important, for all of our patients. And that's something we want you to be talking to your clinical teams about. Obviously, in terms of your health and well-being and just feeling comfortable, again, it may vary, but there really aren't any specific restrictions around that activity. It's really when a patient feels comfortable to resume that. In terms of, I guess, pregnancy, and I know some patients might be thinking about family planning post-transplant, we do want those types of patients to have a conversation with us. Typically, we don't want any unplanned pregnancies before after transplant, especially within that first year, because of the really high dose immunosuppression that you're on. And again, it really, some of the medication that patients are on can obviously make it difficult both on the male and female side of things to conceive. And then also once conception does happen, there are medications that can harm the unborn fetus, okay? But speaking to other activities in terms of driving, after driving, in terms of driving, we want to make sure you're off your pain medication, for example, so that you're not slow or drowsy to react behind the wheel. And some patients are able to sit in traffic for, can you sit in traffic for 20 minutes versus 2 hours, especially here in the GTA with traffic and things like that. That potentially can impact your how you feel to and from your clinic visits. So there are definitely things we try to tell our patients in terms of activity level, but generally it's about, we say about 2 to 3 months post-transplant in terms of, going back to work, for example, is generally where patients may feel more safe to do so.
Great. Well, BJ, I think that was the last question that came in. So thank you so much for your time today. It's Living Donation Awareness Week, I know, at UHN. So we wish you a successful campaign there, and thank you for all that you do to help educate the patients. One last thing that I did want to touch on was part of your bio and the importance of your advocacy in high schools and getting the younger generation to understand and recognize the importance of organ donation and tissue donation. Can you speak to that a touch? Because I think that was very common when I was in high school, and my mom would come in and speak to the groups, but it doesn't necessarily seem that is it a common thread in the Canadian community to target high schools from an education standpoint?
So I know within the GTA, this initiative has been around for at least 5 to 7 years, if not more than that. But it's really a great opportunity for us to co-present as a healthcare professional. So it could be any type of healthcare professional role with either a donor or a post-transplant recipient. And so just speaking with these classes is really a great and different opportunity for myself. And just knowing that, again, at that age of 16, when they're thinking about, starting to drive, that they can actually also think about this important decision and take the opportunity to get more information about it. We don't go there and force any of the students to sign up, but it's really to look for information, really speak to their family and stress the importance of that. So in the event something unfortunately happened to them and they were in a position to become a donor, it would be really your family who would then carry out that decision and that wish. But it really is a great opportunity that I've been able to be a part of here in Toronto. Well,
a fantastic initiative, and I applaud you for doing that. I think talking to the youth is a critical point of interest for our foundation and for the importance of organ and tissue donation. Okay, BJ, thank you again for your time today. Wish you all the best.
Thank you. Bye-bye.
Bye-bye.